Hello everyone. Today we are going to learn about the topic intrapartum fetal monitoring. Now what is intrapartum fetal monitoring? Intrapartum itself signifies or itself defines that is something monitoring of fetal monitoring which is going in the process of the labor. So what is intrapartum fetal monitoring? We simply keep a watch on the fetal condition when there is a process of labor going on. So we can define it as it's to keep watch over fetal condition during labor. So we just in the fetal monitoring we just keep a watch over the fetal condition during the labor. Now what is the goal? Why should we do that? The aim of this fetal monitoring is just to detect the hypoxia of the fetus. To detect the hypoxia in fetus so that if the fetus is suffering through the hypoxic condition, we can initiate management as soon as possible. And to initiate management as soon as possible. Now, if we just avoid this intrapartum fetal monitoring, what will occur? We will not be able to decide whether the fetal is in hypoxic condition or not during labor. If it is the normal labor, or what management should we further conduct. And if the fetus goes into severe hypoxic condition in labor, this might be associated with metabolic acidosis, and this metabolic acidosis will cause a fetal organ damage, and this will ultimately lead to the fetal death. So intrapartum fetal monitoring is of the utmost importance. And in the labor, the baby is subjected to a particular stress. The hypoxic can sometimes be for there might be the temporary hypoxic condition for the fetus, as in the normal labor the baby undergoes a significant amount of stress. In normal labor, fetus has to face some amount of stress. And this is due to, first, the uterine contractions temporarily suspend uteroplacental flow. And the second is with the contractions there is a cord compression. And this leads to there is an interruption in the blood flow towards the fetus. Now we will see why there is a temporary suspension of the uteroplacental flow or blood flow towards the fetus in the uterine contractions. See what happens during peak of contractions, when there are the peak of uterine contractions. Firstly, the myometrial pressure. The pressure that is formed in the myometria becomes 120 mm of Hg, whereas the arterial pressure becomes 90 mm of Hg. So we can see the myometrial pressure is greater than the arterial pressure. So this leads to, that is, the myometrial pressure is greater than the arterial pressure. So this leads to temporary halting of oxygen from placenta towards the fetus. Whereas this occurs in the peak of contractions. Now what happens in between two contractions? When the uterus is relaxed, means there are no contractions. In between the two peak of contractions, what occurs? The intraluminal spiral artery pressure becomes 85 mm of Hg, whereas the intramyometrial pressure is 10 mm of Hg. So clearly it is seen that the myometrial pressure is less than the spiral artery pressure. So what happens in this period? This is done to maintain the uteroplacental blood flow. So what happens? This maintains uteroplacental blood flow. So whatever loss has occurred during the peak of contractions due to the difference between the two pressures is being fulfilled or filled in between two contractions. So now if the fetus is healthy and if the fetus can withstand these two stress which are occurring during the uterine contractions, which are within the limits, then there will be no problem for delivery, as these are the natural occurrence. But from first only, if the fetus is compromised, that is from beginning only the fetus has become hypoxic due to several reasons, if there is a intrauterine growth retardation of the fetus, or if the mother is having an obstetric complication such as the preeclampsia, where there is no proper blood supply to the fetus going on, this fetus cannot withstand this stress and it undergoes the fetal distress. Now the fetal distress term has been abandoned and the new terminology has came up, which is more appropriate, and it is called as non-reassuring fetal status. Now we will see how this fetal monitoring is done. Here I have shown, or I have drawn, the electronic fetal monitoring diagram. This is the abdomen of the female, and the female is lying in the supine position on the bed, and she is in the labor, that she is having the proper uterine contractions, and we are monitoring her, that is fetal monitoring, in the labor room. So now there are the two transducers, which are, this is the first transducer. Now I have named it as transducer 1. Now transducer 1 has to be applied to the maternal abdomen, and this is to be applied over the uterine fundus region. And what this transducer 1 do, which is applied over the uterine fundus? It detects the uterine contractions. It detects the intensity of the uterine contractions. Okay. Then the second transducer, we have to first audify the fetal heart rate to the stethoscope or through the Doppler, and then we have to put a transducer at that region. It might be in this region or in this region. Okay. So transducer 2 is where the fetal heart rate is audible. It has to place where the fetal heart rate are audible. And then this is the machine and this is the graph, and these two transducers are connected, and then there is interpretation which we find over the graph, the fetal heart rate with respect to the uterine contractions. This is the electronic fetal monitoring which has to be done in each and every normal labor, or the indications which are given in the text for this electronic fetal monitoring are if there is a maternal condition such as the hypertension, or if we are inducing the labor, or if the patient is suffering from the antepartum hemorrhage. These are the maternal conditions, and the fetal conditions are told that if it is in oligohydramnios, if there is a multiple pregnancy, that is if the female is having the twins, or if the size of the fetus is small, that is it is intrauterine growth retarded fetus, or during auscultation if you find there are the faulty fetal heart rate, or it is the decreased fetal heart rate, then this electronic fetal monitoring can also be done, excluding the normal labor. These are the conditions where we can perform the electronic fetal monitoring. In this picture, we can see the two transducers. The first transducer is placed over the uterine fundus region, which detects the uterine contractions, and the second has been placed where the fetal heart rate is audible. And these two are connected to a machine where you could see a graph rolling, which will interpret the fetal condition over. And this is also a second picture of the electronic fetal monitoring. Now moving forward. Now further moving on, we will see how this electronic fetal monitoring is done. First, it is done either by the NST, which is the non-stress test, and the second one is through the CTG, that is the cardiotocography. Now what is the non-stress test? The non-stress test itself signifies that the test done to identify the fetal heart rate when the fetus is not under any kind of stress. So in this test, the fetus is not under any kind of stress, that is, we consider there as the uterine contraction. So the test done to identify the fetal heart rate in the absence of uterine contractions, then the test is called as the non-stress test. Monitoring of fetal heart rate during absence of uterine contractions. Then is the CTG, that is the cardiotocography. Cardio, that are the fetal heart rate. Toco, uterine contractions, and graphy, graphical representation. So the cardiotocography is the graphical representation of the fetal heart rate during the uterine contractions, that is called as the cardiotocography. Here we have such kind of a graph where these are the fetal heart rates starting from the 60, 90, 120, 150, 180 and maximum up to 210. And these are the lines for the uterine contractions which will occur. So uterine contractions will be like this, from 0 to 25 or in the range. These are the intensities, these are the pressure which are according to mm of Hg. So now what happens, there are the specific graphical rates for each of the machine. It might be 1 centimeter per minute. The graph rotates at the rate of 1 centimeter per minute, or 2 centimeter, or 3 centimeter. Universally, the graphs, the machine is set upon the 1 centimeter per minute. So if considering that 1, 2, 3, 4, 5, 6 and 1, 2, 3, 4, 5, 6, 6 by 6 box, this is by 6 by 6 box, such that each box, see each first we'll see this is the x-axis and this is the y-axis. X-axis represents the fetal heart rate and y-axis represents the time. So one small box, it's by 10 by 10, that is the x-axis represents 10 beat per minute. The increase in the heart rate is 10 beat per minute. You can see here 90, 100, 110, 120, and the horizontal, that is the y-axis, represents the time, that is the 10 seconds. So this is the graph which represents the heart rate with comparison to the uterine contractions measured in the pressure, that is mm of Hg. And each small box is 10 seconds on the y-axis, and on the x-axis it is 10 beats per minute. We will see what are the components of the CTG. That on what points we can ensure the healthy fetus. First is the baseline fetal heart rate. Second point is the baseline variability. Third are the accelerations. Fourth one is decelerations. The first one will see the baseline fetal heart rate. The normal fetal heart rate, any of the measurement is in the range. So the normal baseline fetal heart rate is normal ranges 110 to 160 beat per minute. This is the normal range. The fetal heart rate of the normal fetus, which is not compromised, is always between 110 to 160 beat per minute. Any heart rate below 110 beat per minute is the bradycardia. Okay, and any of the fetal heart rate above 160 beat per minute is the tachycardia. Now again, this bradycardia divided into two, that is the mild bradycardia or the severe bradycardia. So what is mild bradycardia? The fetal heart rate between 100 to 110 beat per minute is defined as the mild bradycardia, and severe bradycardia below 100 beat per minute is the severe bradycardia. Same goes with the tachycardia. So what is mild tachycardia? 160 to 180 beat per minute is mild bradycardia. Mild tachycardia. And for severe tachycardia, above 180 beat per minute is the severe tachycardia. Now what causes the fetal bradycardia? If there are some serious issues related to the fetal heart or if there is a congenital heart block, or if the fetal is seriously compromised, then we will see the fetal heart rate bradycardia. These are the fetal factors. Now, what are the maternal factors? If the mother is suffering from the hypothermia, if she is under general anesthesia for any of for reason, then it might affect the fetal heart. It might affect the fetal heart rate, and it might show the fetal bradycardia for a sustained time of a limit. Once the anesthesia relieves, again the fetal heart rate can come up to the normal level. So what are the causes for fetal bradycardia? The fetal causes are: if there is a congenital heart block, or a serious fetal compromise. And what are the maternal causes? If there is a hypothermia, or if the mother is under general anesthesia due to any reason. But for this, there is a sustained bradycardia. It is for a specific amount of time. Once the anesthesia is relieved, again there will be the normal fetal heart rate. Now we will see what causes the fetal tachycardia. So what are the fetal causes? If there is a chorioamnionitis, then it might cause increase in the tachycardia, because there might be the chances of the sepsis, there will be the increase in the temperature, so there will be the rise in the fetal heart rate. If the baby is premature, there is no stability in the autonomic nervous system of the fetus, this might also lead to difference in the fetal heart rate. Main reason is if the fetus is in the hypoxic condition. Then there are the maternal factors responsible. If the mother is suffering from hyperthermia, that is, if the mother is having fever, or there is hypovolemia, that is, there is some kind of the bleeding with any other part in the mother, or if the mother is dehydrated, bleeding or dehydration. If the mother is suffering from hyperthyroidism, or if the mother has been given a parasympathetic inhibiting drugs such as atropine, these are the some of the fetal and maternal factors which might cause the fetal tachycardia. So here in this picture we are seeing the bradycardia. This is the severe type of the bradycardia where the fetal heart rate is below 100, that it is first it is at 80 beat per minute, and then we are seeing over here it is 60 beat per minute. And this is the presentation of the tachycardia. This comes in the mild tachycardia or severe tachycardia. Here the fetal heart rate is above 160, that it is 180 beat per minute. Then the second point is the baseline variability. Now, what is baseline variability? Any kind of oscillations in the fetal heart rate is called as the variability. The baseline fetal heart rate is the baseline variability. Now, why these oscillations or the fluctuations in the fetal heart rate occur? See, there is development in the autonomic nervous system, and if this autonomic nervous system is properly developed, that is the sympathetic and parasympathetic nervous system is properly developed, we will see the fluctuations in the fetal heart rate. So there will be the increase and decrease in the fetal heart rate. If the sympathetic and parasympathetic are coordinating well amongst themselves, we will see the baseline variability. So why is this seen? It's the development of the autonomic nervous system. That is the sympathetic parasympathetic system. This sympathetic and parasympathetic system acts via the sinoatrial node, that is the SA node situated in the heart. They act through this. There is a push and pull mediated system. And this push and pull mediated system will show us beat to beat variability, or they will show a moment to moment oscillations or fluctuations in the fetal heart rate. So in this concept, what is seen? The sympathetic, what is this push and pull? The sympathetic system is responsible or is the accelerator influence. That is what we'll see. There is an increase in fetal heart rate. Whereas the parasympathetic system is the decelerator influence. That is the decrease in the fetal heart rate. Now these act through the SA node, or which we also called as the pacemaker cells of the heart. So there will be the increase and decrease, that this leads to beat to beat or moment to moment fluctuations in the heart rate, and this is called as the baseline variability. Now we'll see to the diagrammatic presentation. If this is the x-axis, where these are the fetal heart rate. So this is 110. This is 120, this is 130 and 140. And this is the y-axis, which is for the seconds or the time, and these are the fetal heart rate. If the baseline of this fetus is from 110 to 120, so this will be the pattern. And what is the variability? There will be the fluctuations in the fetal heart rate. This is the baseline, that is 110 to 120. So what is the fluctuation? We could see from 110, and this fetal heart rate has been come up to 110. So what is the baseline variability? It is 10 beat per minute. The baseline is 110. See over here. 110, 120, 115 beat per minute. These are the fluctuations. And what is the baseline variability over here? It is 10 beats per minute. This is the baseline variability. Now, the baseline variability might be first absent, where there is no variability. Means if these are the fetal heart rate and this is the time, that is 110, 120, 130 beat per minute. This will be the baseline. See over here, we don't see any fluctuation or we see no any variation. It is straight. No fluctuations is seen. This is the absent variability. Second is the minimal variability. What is minimal variability? There is a variability which is less than 5 beat per minute. Again, we'll draw a diagram. This being the fetal heart rate. This is 110, 120 and 130. So in between 110 and 120 there might be 115 beat per minute. And this is the baseline. See, we could see a little bit of variability over here. So it is less than 5 beat per minute, not more than 5 beat per minute. This is the minimal variability. Then third one is the moderate variability. It is from 6 to 25 beat per minute. Again, I'll draw a diagram. These are the fetal heart rate. 110, 120, 130. 6 to 25. Now we have seen the baseline is up around 110. This will be the variability. What is the variability over here? It is 10 beat per minute. And here we could see it is 20 beat per minute. The fetal heart rate has been increased by 10 beat per minute or 20 beat per minute. Now this I have shown in the upward direction. This can occur in the lower form also. See, this is 100, 110, 120 and so on. So if the baseline is in between 110 to 120, this can also occur, okay? So now here also you can see the variability of 5 beat per minute and here 10 beat per minute, okay? And the fourth is the marked variability. Where the variability is greater than 25 beat per minute. If this is the baseline, there is a marked variability. Similarly, it could go down also. See, 10, 20, 25. This is 25 beat per minute. So first one is absent, where you see no variability. It is the plain line, single line. Then is the minimal variability, where the variability is less than 5 beats per minute. See here, it's somewhere in between 110 to 120. It might be 114 or it might be 115. Then comes the moderate variability. It is between 6 to 25. See, 10 beats per minute, 20 beats per minute, and it is greater than. This is above, and it can sometimes go below the normal baseline. And this is the marked variability. Now the third point we will look are the accelerations. Sometimes we see an abrupt increase in the baseline. Aberrative increase from the baseline of fetal heart rate. And these are called as the accelerations. Now there might be some limit. So increase in the baseline fetal heart rate of 15 beat per minute for 15 seconds in 20 minutes NST. See, normally we do NST of 20 minutes. So increase in the baseline fetal heart rate of 15 beats per minute for 15 seconds. So how much this increase should be? It should be of 15 beat per minute. The increase in the heart rate should be 15 beats per minute. So if the baseline is 110, then it should be, the heart rate should go up to 125 beat per minute or above, and it should last for 15 seconds in 20 minutes of NST. And there must be 2 accelerations in 20 minutes of NST. So if these are the graph, this is the time, 100, 110, 120, 130 and so. There might be, this is the baseline, then it should increase up to this C. So here we see the acceleration of around 20 beat per minute, and this should last for at least 15 seconds. And in 20 minutes of NST we should at least get 2 accelerations. So the maximum is 15 beats per minute and it should last for 15 seconds. Now, why these accelerations occur? These accelerations occur due to the fetal movements. The fetal movements or activities intrauterine going on results in this acceleration. Or if the fetus is stimulated by stimulations of uterine contractions. Or it could be also the fetal stimulation during pelvic examination. So these are the some causes which might result into the accelerations. So in 20 minutes of NST, if we do not find such kind of accelerations, but there is the presence of the baseline variability and there are the absence of acceleration, it does not signify that the fetus is compromised or the environment is unfavorable for the fetus. Now, are the accelerations good or bad? Yes, they are 100% a good sign, and the accelerations also signify the good healthy fetus which have the proper fetal movements and the proper breathing movements. Now we will move forward towards the 4th point, that are the decelerations. Sometimes in the CTG or on the NST, we see there is a gradual lowering of the fetal heart rate. So there is a gradual decline in the fetal heart rate, and this gradual decline in the fetal heart rate is called as the deceleration. And again, after some amount of time or after some seconds, these fetal heart rate then again return to the baseline, to the normal baseline. After some amount of time, it again return to the baseline. So if this is the graph, fetal heart rate, this is 110, 120 and 130, and if this is the baseline, we see a gradual decline, and then again it comes towards the previous baseline, and these are called as the deceleration. Now deceleration, how much there should be the decline and for what amount of time the decline should continue is also defined. So the deceleration should be of 15 beats per minute, lasting only for greater than or equal to 15 seconds. Obviously in 20 minutes of NST, if we see this, then there might be some problem, or it just signifies the physiological response of the fetus. So here we will see if this is the baseline, and between a 120 or 130, if it's 125 to 120, the decline is of C. From 125 it has come to 110. So the decline should be for the fall of the fetal heart rate should be of 15 beats per minute, and it should last for greater than equal to 15 seconds. These are called as the decelerations, and the decelerations coincide with the uterine contractions. So if we have to see the decelerations during normal labor, you have to go up for the cardiotocography. Now depending upon its coincidence with the contractions, the decelerations are divided into further 3 types. So the first one is the early deceleration. Second one is the late deceleration. And the third one is the variable deceleration. How does the fetal heart rate respond to the uterine contractions? It's signified in this: early, late and the variable deceleration. First we'll see the early deceleration. Now what is early deceleration? The early deceleration, we'll see it through the diagrammatic representation. So if this is the baseline and this is the deceleration, and again it is, this is the fetal heart rate, and these are the uterine contractions I'm going to draw, and these are the uterine contractions. Now when the nadir, this is the nadir of the deceleration, when the nadir of the deceleration coincides with the peak of the uterine contraction, it is called as the early deceleration. That is, the decline of the fetal heart rate simultaneously starts with the uterine contractions, where the nadir of the deceleration and the peak of the uterine contractions coincide, and the fetal heart rate again returns to the baseline with the subsidation of the uterine contraction. Such deceleration is called as the early deceleration. So we will write the definition. When the decline of fetal heart rate starts simultaneously with the uterine contraction, such that the nadir of, this is called the nadir, such that the nadir of deceleration coincides with peak of uterine contractions and fetal heart rate returns to normal baseline as the uterine contractions subside. This is called as the early deceleration. So we'll see this and this part. There is a coincidence between the nadir of deceleration and peak of the uterine contraction. This is called as the early deceleration. Now, what are the other characteristics of deceleration? The early deceleration are uniform, means they occur with every contractions. So the next point is early decelerations are uniform. That is what they occur with each contraction. Means as there will be the uterine contraction, you will see the deceleration in the 20 minutes of NST, or in every graph you will see the deceleration with the uterine contraction. So the early deceleration are uniform as well as they are repetitive. See, they will occur with each contraction, so they are repetitive. And the deceleration will be of same magnitude, that each of the deceleration will be, it will be either 15 beats per minute and it will last for the same time interval. So they are repetitive also and they are of the same magnitude. Now, how much this deceleration will fall? What will be the value, or up till which value this fetal heart rate will fall? It will not fall, or it will not drop 40 beats per minute. Now see, if the baseline is 120 or it is from 120 to 130, then it will never fall below 80. It will always remain till 100, 110. It will not fall below 80 beats per minute. Now the next question comes, when are these early decelerations found in the cardiotocograph? See, what happens, as there is descent of the head of the fetus into the pelvic cavity, there is compression of the head. We all know that. Now what happens during the uterine contractions? With each uterine contraction, the fetal head is pushed down into pelvic cavity. So there is the head compression. So with each uterine contraction, there is the head compression. Now what happens due to head compression? The parietal bones are compressed such that the sagittal suture, the width of the sagittal suture decreases, which is called as the molding. Now if the uterine contractions are proper, what will happen during compression? Sometimes what will occur, the sagittal sutures, the parietal bones at the site of the sagittal suture will overlap around each other. So we'll write over here, there is the molding. And due to this head compression and overlapping of the parietal bones over each other, by the compression or by the decrease in the width of the sagittal suture, there is a pressure over the head, which we will see by this pattern, that is the early deceleration. So molding, so we see the early deceleration. Now is it a good sign or bad sign? Nor it is a good sign, nor it is a bad sign. When you see early deceleration and it's the same magnitude and it's returning again with each contraction, finishing of each contraction, if it is again returning back to the normal state, and there is no any harm to the fetus going or to the mother, there is no need of the rush. You can allow the process of the labor to be continued as it was going on. There should be no interventional management to be done. So there must be no rush. If we see the early deceleration, it is the physiological response which is occurring due to the head compression with each uterine contractions. So you see the early deceleration with each uterine contractions. After the early deceleration, now we will see the late deceleration. So what is the late deceleration? This is the response of the fetal heart rate to the uterine contractions, where there is the gradual and the symmetrical decline in the fetal heart rate, which begins after the uterine contraction has started. It do not begin with the simultaneously with the start of the uterine contraction. There is a decline in the heart rate after the uterine contraction had started. So we'll see over here, if this is the fetal heart rate, these are the variable baseline. There is the gradual decline and the symmetrical decline in the fetal heart rate. What will occur with the uterine contractions? The uterine contraction has already been started. So here we'll see this do not occur simultaneously. Okay, the decline, the fluctuation or the decline of the fetal heart rate occurs when the uterine contraction has already started, and the difference between the peak of the uterine contraction and the nadir of the deceleration should always show the lag of 20 seconds. So there should be the time lag of 20 seconds in between the peak of the uterine contractions and the nadir of the deceleration. So how could you define the late deceleration? The gradual and the symmetrical decline of fetal heart rate after the uterine contraction has started, and there must be lag of 20 seconds in peak of contraction and nadir of deceleration. Nadir of deceleration is called as the late deceleration. Now it also shows the same characteristic as the early deceleration, that it is uniform, it might be repetitive, and it's of the same magnitude. Now, is the late deceleration good sign or bad sign? Yes, it is the bad sign. It suggests fetal hypoxia and uteroplacental insufficiency. That is, the fetus is not getting the adequate amount of oxygen as well. Uteroplacental insufficiency, the fetus is not getting the oxygen as well as there is improper blood supply to the fetus. So you have to carry out the delivery as soon as possible. You have to just take out the fetus as early as possible. Now, why we see the late decelerations? There are different factors which can cause the late decelerations. First, you have always we have seen over here there is a uteroplacental insufficiency. Now, why this will occur? If there is presence of any placental pathology. If we see towards the maternal causes, it might be the maternal hypertension. If the patient is showing the symptoms of the preeclampsia, or the patient is having the diabetes, that is gestational diabetes mellitus, or if there is abruptio placentae. These are the causes which will come under the placental pathology. So it might be hypertension, diabetes, or placental abruption. In these cases, we could see the late decelerations in the graph. Now the second cause might be if there are the increased uterine contractions. Now why there might be the increased uterine contractions? If there is an improper use of the oxytocin, if you are augmenting the patient, initiating the labor by the use of the oxytocin, and if you have used the improper dose of the oxytocin, then there are the increased uterine contractions. Improper use of oxytocin. If you have not gradually increased the dose, if you have suddenly increased the dose, it might lead to improper uterine contractions or excessive uterine contractions, which will lead to the fetal hypoxia and uteroplacental insufficiency. There will be the compression of the cord, which is not bearable by the fetus. Third, if you have given the epidural analgesia, so if there is a epidural analgesia, there will be the hyperactivity, uterine hyperactivity due to the oxytocin stimulation, and if there is the presence of any placental pathology due to the maternal hypertension, maternal diabetes, or due to the placental abruption, you will see the late deceleration. Late deceleration is a bad sign. You have to carry out the delivery as early as possible. Now the third deceleration is the variable deceleration. Now what happens in this deceleration is there is a sudden drop or abrupt drop in the fetal heart rate. Abrupt drop in fetal heart rate, such that the drop or the declination of the fetal heart rate starts with the onset of uterine contraction. But the nadir of deceleration is reached within 30 seconds. So if these are the fetal heart rate, first I'll draw the uterine contractions. Now if this is the uterine contraction, see, okay, this is the peak of the uterine contraction. What happens? There is the fetal heart rate will decline with the onset of the, this will be the nadir. So there will be the sudden drop, see, with the onset of uterine contraction, but the nadir of the deceleration is greater than or equal to 30 seconds. So the nadir of the deceleration will reach after 30 seconds after the contraction. Now this decrease must be between 15 beats per minute, and the decrease or the deceleration lasts for 15 seconds to 2 minutes. So this deceleration will prolong from 15 seconds to 2 minutes. But the amplitude of the fall must be greater than or equal to 15 beats per minute. Okay? And this deceleration varies. Means if over here, if it will be a it will be of 20 seconds. For the next uterine contraction, it will be of 15 seconds, and then in the next contraction it will be of like for prolonging for almost 1 minute. So these decelerations are variable deceleration, hence called as variable deceleration. So these are not uniform and of not same magnitude. Okay. The prolonging time in the seconds differs from one deceleration to other deceleration. Now, why this variable deceleration occurs? This occurs due to complete or partial umbilical cord occlusion. If there is a complete or partial compression of the umbilical cord, we will see the variable deceleration in the graph. This complete occlusion of umbilical cord produces an abrupt and the jagged appearing deceleration of the fetal heart. So, in this variable deceleration, it was found in some experiments that when the variable decelerations were seen in the graph, there was a 50% reduction of the umbilical blood flow towards the fetus or from the fetus. Now we'll draw another diagram. So there are different degrees of partial occlusion. Sometimes what happens, the occlusion of only vein occurs, which reduces the fetal blood return, the blood which is coming from fetus through the umbilical vein. That only when this umbilical vein is occluded, only the return is affected. So what happens? This triggers the baroreceptor mediated acceleration. But as this we will see only in the starting of the uterine contraction. But as the intramyometrial pressure increases, as the intensity of the uterine contraction increases, the umbilical artery also get occluded. So whole umbilical cord gets occluded, that is the complete occlusion of the umbilical cord, and then we see the sudden, that is abrupt drop, and we see the nadir of the deceleration. And as the pressure decreases, as the uterine contraction slowly subsides, we again will see a sudden acceleration, and then again it will come to the normal baseline. So we'll start the diagram. So there are the degrees of occlusion. So it's like partial occlusion. Partial occlusion when there will be the umbilical vein occlusion, and complete umbilical artery is also affected. Now see here, I have drawn a diagram. These are the fetal heart rate, okay, and this is the uterine contractions. This blue pen resembles the umbilical vein, and the red pen shows the umbilical artery. Now see, as there is the starting of the uterine contractions, where the intensity of the uterine contraction is low, there is the partial occlusion of the cord, that is there is the occlusion of the umbilical vein, that is the blood returning from the fetus is affected. So we see a partial rise in the fetal heart rate, that is we see over here the acceleration, okay. Now as the intensity increases of the uterine contractions, there is a complete occlusion of vein there is a complete occlusion of cord with the obstruction of the umbilical artery. Now the fetus is fully hypoxic, so we will see a sudden decline, that is the nadir of the deceleration. Now as the intensity slowly decreases, there's a release, sorry, it will be over here. So as the intensity decreases, there is again a proper flow in the umbilical artery and there is a partial occlusion of the umbilical vein. So again the fetal heart rate suddenly rises. Here also there is an acceleration. And as there is a subside, again there is a proper flow in the umbilical vein and the fetal heart rate also comes to the normal level. This is called as a shoulder, where you see the acceleration as well as deceleration. This is called as the shoulder. Now the variable deceleration reflects that the fetal heart rate reflexes either the blood pressure changes occurring due to occlusion of the umbilical artery, or there is an interruption in the blood flow, umbilical flow, or if there are the changes in the oxygenation, that is supply of oxygen to the fetus. So variable deceleration signifies first, the fetal heart rate reflexes blood pressure changes which are occurring due to restricted umbilical blood flow. Or second, improper supply of oxygen to fetus. These are the variable deceleration represents this too. Now, the fetus in this variable deceleration experiences recurrent periods of hypoxia which occur due to the umbilical cord compression. So, the variable deceleration is very important to differentiate between the pathological variable deceleration. So, the ACOG, that is the American College of Obstetricians and Gynecologists, have suggested that the recurrent variable decelerations with minimal to moderate beat to beat variability are indeterminate, means they don't have any that much significance. But if the variable decelerations occur with the absent of the variability are abnormal. So according to ACOG, it is said that variable decelerations with minimal to moderate beat to beat variability are indeterminate, whereas the variable decelerations with absent variability are abnormal. So it's very important to differentiate between such type of variable deceleration. So this was the non-stress test and cardiotocography for you guys. Thank you. Here in the picture of early deceleration, we will see that the nadir of the deceleration coincides with the peak of uterine contractions. Also, the early decelerations are repetitive, that they are occurring with each uterine contraction. And here in the late deceleration, we will see there is a gradual and symmetrical decline of FHR, that is the fetal heart rate, but they are occurring, the deceleration is occurring after the uterine contraction has been started. But these are also uniform, repetitive and occur after each uterine contractions. Here in the variable deceleration, in the mild variable deceleration, we see that there is abrupt drop in the fetal heart rate and the nadir of deceleration has been reached within 30 seconds after the uterine contraction has been started. Where in the severe deceleration, it has been prolonged more than 15 seconds.